and thank you for joining our first webinar of the ObGYN Action Group. I'm Mike Genord. I'm an Associate Medical Director here. Many of you know me. We're fortunate to have Jeff Burton here, who's a specialist here in performance improvement and is working very closely with the Action Group and Steering Committee. Kathy Stark, one of our colleagues, she actually chairs the ObGYN Steering Committee and is the voice of the colleagues in working with United Physicians. And John Euclid is also here, another colleague of ours who sits on the steering committee with Kathy. So what we're going to do is go through some slides. Hopefully all of you can see the slides. And Kathy's going to start, and then we're going to kind of flow through. We'll take some breaks along the way. A few things I want people to keep in thinking about during the conference is Kathy's going to need more help with action and work groups. So we're looking for you who are participating to reach out to Kathy and volunteer your time and energy to some of the issues we'll be talking about. Secondly, this will be followed up with Office Manager Forum to reinforce everything that we are going to discuss with the practitioners. The United Physicians will also be meeting with the managers of your offices to build kind of momentum in being successful in these new endeavors. So with that, I'm going to step back and let Jeff and Kathy and John take over, and we'll be pausing for questions along the way. Kathy.
Okay. Basically, this is probably the first time most of you are hearing about our group, but this group has been working together for the past 9 months or so. Mike asked a few of us docs from Troy, Royal Oak, Bolton, Floyd, and private practice to volunteer our time to meet and try and help design a strategy that we could present to our United Physician members. So we've been looking at a lot of data at specific incentive programs from specifically Blue Cross recently. And what struck us, I think, at our first meeting that kind of prompted us to do this, there are funds and reimbursement available out there for all of us in private practice that we are not currently getting. In fact, in 2012-2013, none of the United Physicians ObGYNs have qualified for the Blue Cross incentive payments. And we really are hoping to turn that around for our groups and for all of us here. But as we came to find out, this has to be a joint effort. So our purpose is to guide those willing ObGYN practices throughout the United Physician Network, which we are referring to as an ObGYN Action Group, working with United Physician staff to achieve the following goals. First of all, to improve efficiency and eliminate waste from unnecessary services in all settings of women's care while maintaining high-quality standards. That's real important, of course, to you as it is to me. And I think when we started looking at our scorecards from United Physicians, we see a big variation in practice patterns. And there's some variation, of course, is acceptable and understandable, but we really would like to work hard on bringing everybody kind of towards the middle ground where it's appropriate. But it's really a nebulous thing. We're going to have to come up with some recommendations, and that's a lot of work trying to figure out what's clinically acceptable to all of us and efficient. We want to help position our ObGYN practices to be competitive for incentive payments from payers. Our model of reimbursement traditionally has been rewarding a volume. The more procedures or patients we see, the higher our income. It's switching. It's already switched in primary care, and it's coming to the specialists. It's going to be reimbursement for value. And so we have to be a participant in setting what these metrics are going to be. If we don't do it ourselves, someone else is going to do it for us, and I think it's very important that you understand, as I have come to understand, that you have to come to the table if you're going to have a voice. No good to sit in the back seat and complain anymore. Number 3, we're going to select performance metrics and clinical areas of focus with the support of the United Physician staff that leads to the most efficient care of our patients while ensuring success with the value reimbursement. And we want to maintain formal, ongoing communication channels that foster collaboration and action. So with that, I'm going to turn it over to Jeff. Jeff's going to describe our playbook.
Yeah, so I'm going to go through a few different, I guess you could call them high-level items, really just to set the stage for our discussion at the second half of the hour, where we're actually going to get into some more details and areas of clinical focus moving forward. But I thought that we could bring some concepts to you first that are probably important to understand. So first, Kathy mentioned the playbook. This was kind of born here at United Physicians. It was an idea to really support the steering committee with the necessary tools to play the game. These tools include data, all the measures from the different health plans, what are the key terms, how are these incentive programs affecting the OB-GYNs, and basically giving the steering committee the right tools to kind of lead the rest of the OB-GYN colleagues through this change. This actually will be something we've decided to make available via an electronic document. We'll work with the steering committee if you want to see a copy of that, but really the purpose of today is we've worked with the steering committee to go through all the data and look at all these resources and give you 3 or 4 different areas of focus so that you don't have to comb through 30 pages of this playbook. But it will be available for you along with these slides of today's presentation if you wish to reference it. So there are essentially, and Kathy had mentioned Blue Cross, there's a lot of activity right now going on at Blue Cross to move the needle from fee-for-service to fee-for-value in the specialist community. And it really focuses around 3 different programs. First is the PGIP initiatives. The second are the specialist uplifts, and the third is the organized system of care. Many of you have probably heard the term PGIP before, the Physician Group Incentive Program. This essentially is just a funding mechanism to create a pool of incentive monies that are distributed either to the PO or, in the case of the specialist uplifts, directly to the OB-GYN practices. So with the PGIP initiatives, we, United Physicians, are evaluated on our entire attributed primary care population, which are treated by specialists too, for the overall care that they're getting in various areas. They look at generic dispensing, they look at HEDIS scores, they look at women's health measures. Then there are specialist uplifts that go directly to the OB-GYN practices. In 2013, that was the first year for the specialist uplifts, and Kathy had mentioned we didn't have any practices that received that, and our goal really is to turn that around. So there's a 20% bonus, if you wish, that's attached to the E&M fees that you bill Blue Cross if an OB-GYN practice was designated. And finally, our goal is to become an organized system of care. We use the term, or Blue Cross uses the term OSC. It's really their term to mirror the ACO, or Accountable Care Organization model. This is the end goal where all of the providers, so facilities, specialists, primary care providers, are all evaluated collectively on the total cost of care for a common patient population. I had some terms before. I mentioned HEDIS. HEDIS is the NCQA quality-based measures that are very common to the primary care physicians. And when I mention PO, I'm referring to the physician organization, and that's us, United Physicians. So I just wanted to give a few details on the uplifts and the organized system of care. So the uplifts, like I'd mentioned, is an increase in the office visit fees, which are the E&M CPT codes that your office bills to Blue Cross, and they're given directly to the specialist office. How do I become eligible as a specialist? Well, first of all, you have to be nominated by the physician organization. So in 2014, it's United Physicians' goal to nominate all of the OB-GYN specialty practices, and in which case Blue Cross then evaluates all of the practices across the state within each specialty and compares them to one another. The goal we're trying to shoot for is to be in the top third of all of the practices. That's kind of where they draw the line as far as who gets the uplift and who doesn't. They're doing it this way because they're trying to align essentially all the work they're doing with the primary care physicians in the hospitals. So each sector, you can consider it in 3 sectors: specialty care, primary care, and the hospitals. There are essentially these incentive payments that are distributed to each one of those sectors for their performance. And like I had mentioned before, we're all moving towards becoming an organized system of care. So it'll be essential that we collaborate because we're all in this together. We're all responsible for a total population. And that's really the movement from the fee for service to fee for value. Go to the next slide. This is just an example of the metrics that Blue Cross is using for the ObGYN uplift. Some of these are very general. The CAVE metric up on top, we're going to explain that at the very end. CAVE is a company that does reporting for Blue Cross. We get down to some very specific quality measures too, but the one thing to note here is that these are all population level metrics, and that actually means they're evaluating the population of patients that may have seen you but also get treated by primary care, that also get treated in the hospital. So it's not just the care that you deliver in your office, it's the total care that's delivered for that patient.
I would just like to add something there to add to Jeff's point, is that you are also, the population is, you can't study for the test. We're all in this together, meaning the PO's attributed population is judged as a whole, not you as an individual. The only practice level measurement that you can see on the screen is meaning you will be directly evaluated on that, but the rest of the other metrics are how we're doing the whole begin together.
Great point. Thanks, Mike. So I'd like to move to the next slide and just talk about moving forward and how we can achieve the uplifts for ObGYN practices in 2014. There are goals that we have as a physician organization, and I mentioned one of them. It's to nominate all of our ObGYN practices for 2014. But also we're going to continue to support the steering committee with data and resources and hopefully some ad hoc sub-work groups that come off of today's presentation. We're kind of here as a service organization to support you with everything that you need to be successful. And as an ObGYN, your goals should be focused around adopting the key measures from the playbook. We're going to talk about those key measures in a second. And focus on some areas to improve efficiency of care, not just within your office, but with the hospital or in coordination with the PCP, because like we've mentioned a couple times, the success is dependent on how we do together as a group. Okay. Just want to provide you a quick quote from Dr. Berwick, who is the former administrator of the Centers for Medicaid and Medicare Services and the CEO and president of the Institute for Health Improvement. He said that the ACO, the Accountable Care Organization, it's not a financing organization, it's a care organization with patients and families at the center. So the primary care physicians have been working on the patient-centered medical home concept, which essentially puts the patient at the center of care. And they're working on the very same thing that we're going to be working on. So it's important to know that this care is focused around attending to handoffs, managing resources, reducing waste, reducing dependencies on hospital care, and being proactive. We're all kind of working towards improving outcomes. So I thought this was a really good quote to kind of explain what an ACO is. And this is the OSC model. So there's all these terms. Like I mentioned before, the OSC stands for the Organized System of Care. This is simply Blue Cross's term. It's really mirroring the model of the Accountable Care Organization. So in this model, each provider sector has their own ways to improve quality and reduce the cost of care. But at the end, the total cost of care for that population that may be seeing a PCP, may be treated by an OB-GYN, and may end up in a hospital is the total cost of care for that patient. So this is just a pictorial representation of the OSC model. All right, so that's all nice, but how do we get there? This is going to lead us into what we really want to focus on today, and that's talking about areas of care related to OB-GYNs. So first is the adoption of some quality measures to close gaps in care. We're going to talk about immunizations and pap smears as potential opportunities. We're also going to focus on some utilization measures, such as pharmacy. There's generic use and there's total pharmacy costs that are a big part of the total cost of care. These are episodes that I think we have a lot of opportunities with generics and the use of oral contraceptives. And finally, we want to, with utilization, look at the total cost of care around the newborn episode. This is a significant portion of the costs attributed to the OB-GYN patients, and we're probably going to need a longer-term focus on this because it's a little bit more complex, but we're going to start with some low-hanging fruit with the quality and the basic utilization measures. In addition to that, we, like Dr. Genord had mentioned, we're just going to go back a slide. Dr. Genord had mentioned that there's a office managers meeting with UP where they're going to be working on the patient-centered medical home neighbor capabilities. You may have seen these, you may have not. There may have been a practice delivery consultant from UP out in your office already, but these essentially are the very same capabilities that the primary care physicians are working on, and they're important because there's so many areas of care that probably overlap. So just something to be aware of when the UP staff are in your office working with your office managers. And it really is about collaboration, not just between the OB-GYN colleagues, but collaboration with the hospital, specifically the MFMs, and collaboration with the PCPs. We can move to the next slide. Just wanted to give you a little bit more on the coordination with the PCP. All the activity that's gone on with the patient-centered medical home has actually proven some pretty good results. So the implementation of these PCMH neighbor capabilities that will mirror what the primary care physicians are doing can potentially lead to the very same outcomes we've seen already, and this is through 3 years of the Blue Cross PCMH designation program. And the idea is that if you're working on these very same capabilities, we can get to a lower per member per month costs for adults, which we've seen for primary care. We can reach a higher generic dispensing rate. So in addition to focusing on the very clinical processes, there's also processes in your office with the patient-centered medical home neighborhood capabilities, such as chart prep or test tracking, that could yield some of these results and essentially lead us to success with the specialist uplifts. Okay, so I'm going to actually turn it over back to Kathy to go a little bit deeper into the areas we've noted through the playbook and all the data that we've looked at so far, starting with immunizations.
Okay, thanks, Jeff. Well, one thing I would say is that our steering committee attempted to look for low-hanging fruit. When we say that, we mean things that are not too painful to implement, that will give us an improvement in our quality scores, not decrease our revenue, and maybe even improve our revenue overall, and really help move us into better practice using current data. So there were a few initiatives, and one of them is generic dispensing rate. One is vaccination, and the other is pap smears. So I'm going to start with the immunizations. We all have probably heard of the recommendations for HPV vaccines, and we now are being judged by what percentage of our patients are actually getting the first vaccine and a completion of the series. And this is working together with our primary care docs. So we've got to find a way to communicate when we see a patient, if we're both seeing a patient, both the primary care and we are, that we let them know, or somehow they find out that the HPV vaccine has been started with us, and we all can see if it's been completed. Tdap with pregnancy, is now recommended, and we're getting looked at for vaccination rates there. Influenza vaccine, primary care primarily is doing that, but we also know that in influenza rates with our pregnant patients, we're doing that too. So longer-term goals, I don't think any of our OB-GYN practices that I'm aware of are participating with MICR right now. Maybe some of you are. Seems like a black box to me, but I know that United Physicians is going to help us get involved in MICR, and we'll be able to directly communicate through the existing programs the vaccine notification, and that'll help our communication with our primary care our primary care docs that we work with. Oh, MICR, yeah. What's MICR? You want to tell us what MICR is, Jeff? Yeah.
MICR stands for, I think I got this right, the Michigan Childhood Immunization Registry. So it's a statewide registry where anyone interfaced with it can look to see if a child has received a vaccine, and once the vaccine is given, you can report it to MICR, and then that way the health plans actually use MICR as the source of truth when they're looking at the data.
So what's the big advantage to us with this initiative is that it not only improves our quality scores, it helps our patients. It's actually better for patient care, and it can increase your bottom line because there is revenue from each dose of vaccine that you give in the office. There is a way to get reimbursed for it. United Physicians has a vaccine purchasing program. Many of us already purchase our vaccines from them. And all you really need to know is that you need a policy and procedure set up in your office, and we have several models with different practices who are already doing this. So, we think we can reach out to everybody to get on the same page. And if you haven't already started giving vaccines in the office, get a hold of United Physicians, and they can help you set up a process. You can actually call any of the other, talk to your colleagues who are doing it. I know we've got a good program going in our practice, and it has not been a money loser. It's been a revenue builder. There's a little number at the bottom of the slide if you want to participate in the purchasing program through United Physicians.
The purchasing program really just provides you ease of purchase and significant discounts that come, and we listed the three here that would probably be relevant to you, the Gardasil, Fluzone, and Avicel. So we work through Merck and Sanofi Pasteur to purchase these vaccinations at a discount for you.
Okay. Next, there is a Choosing Wisely campaign that our patients are seeing. It's being probably sent to them directly in the mail and published in some of the Blue Cross literature that I've seen. It's called Choosing Wisely. And we have a slide about that if you're wondering why these two things come up. You should look at this and see what your patients are seeing. 5 things physicians and patients should question. And they're talking about induction of labor, early induction, and then they talk about the routine Pap test. And, I know this has been a big controversy because a huge change for us as physicians and as our patients in coming for their annual Pap smear. But I think the time is really now to get on board with the new screening initiatives. If you have not yet given up the yearly Pap smear, your patients are going to be understanding this. They're going to ask you, and it's good for us to all practice the evidence-based guidelines. Also, don't overtreat mild dysplasia, and they're telling patients that this doesn't need to be treated. And then the final one, which turns out to cause a lot of angst, but there is no role for CA-125 routinely for ovarian cancer screening, even though I get it from my patients, as you probably do too. But there's not good evidence that it's a good screening test, and the potential harms outweigh the benefits. So I just wanted you to see that form to start with, because that's what we picked, a couple of those initiatives that the patients are getting told and that are good evidence-based measures. And we're going to incorporate that into our first step in trying to get the low-hanging fruit. So let's go back to the other slide. So the Pap test screening, routine screening once every 3 years if you use cytology plus HPV testing. Some docs may want to go to 5-year screening. I think if you're still doing yearly, your first step should be to 3 years, and then it'll be an easier sell 3 years from now to go to 5 years. But for right now, our practice has adopted the every 3-year cytology since 2009, and we've had really great success with our patients accepting it. We've not lost any patients from their annual exams because of that. It's all how you present it to the patient, you know, what the components of their yearly gynecologic exam are. It's not all about your Pap smear. And if you have any doubts, can that work, feel free to give me a call, or any of the other practices who have already adopted it. And I think everyone I've talked to has been able to successfully implement that. The other part of the Pap test is test tracking, system and coordination with the primary care providers. Under the patient-centered medical homes, these primary care docs have to report that their patients have their routine screening. And if they don't know that you've done it, you may end up with a duplication of a test. So we're working with United Physicians. They have a database called WellCentive that all of Beaumont reference lab testing goes into, so specialists can look that up. And we've got to, I'd like to put together a subcommittee of our steering committee to try and work with a system of reporting back to primary care doctors when we see a patient for an annual that's not too painful, because it is a really, it can be difficult to write a letter every time you see an annual patient or whatever. And the primary care docs don't necessarily want to get a lot more correspondence on things they don't need. But we do need to test, track, and coordinate. So we've got to work on that. But for now, let's see if we can't move more of our practices into the every 3-year cytology plus HPV testing. The second part of this is to not do routine CA-125 and transvaginal ultrasounds for ovarian cancer screening. And that, I think, speaks for itself. If you have any questions, let us know later.
And that is an opportunity where we can work with our PCP colleagues to also discourage that behavior, because we're often on the receiving end of that test being done inappropriately. I just want to highlight one thing under Pap tests, just going back to, if you decrease Pap smears 2 out of 3 years, you significantly decrease the cost of care, total cost of care of that annual exam that didn't affect your revenue, meaning we've eliminated 2/3 of the tests going to the lab that the insurance companies are paying for by this simple measure. So it has a significant impact on the total cost of care of an annual exam.
Okay. I think we'll go to the next slide. And John, you want to talk about this?
Well, I think that another part of the low-hanging fruit that we talked about was pharmacy costs and the lack of, the generic use rates being so low. So, you know, I can speak from the fact that being on the employed side, we've been able to increase our generic use rates forcibly, basically, because our contact with pharmaceutical reps are actually pretty limited. So, you know, I can speak from experience that I believe that if we do limit our exposure to pharmaceutical reps, what impact will that have? Well, I believe it will increase generic usage rates And as a start to the conversation, I think that all of us have had significant exposure to pharmaceutical reps, and we understand what their goal is. Their goal is to promote the use of their medications. Unfortunately, their medications are generally much more expensive than the generics. In order to do that, they gain access to our staff. They offer, free lunches. They come in. They almost, at times in certain offices, and when I was in private practice, I felt that they had an open access to my office. And I think that our relationship with the reps is something that we could conceivably, change, and it will have an impact. One of the first things is just generally the idea of maybe limiting pharmaceutical reps to have access only to the physician. They have to make an appointment. They have to come in and talk directly to the physician. Just doing that will discourage their kind of open door policy. The other thing that was actually found was the DAW, or writing DAW on scripts by mid-level providers, was actually significantly increasing the use of brand name medications for some providers. And a policy where mid-level providers are possibly banned from writing a script that has a DAW on it, and only a physician can write that script, may be something to consider by physicians. Other things to consider is just the use of different medications that are lower cost, that are just as effective. Efficient use of resources for uncomplicated UTI, using the low-cost antibiotics first, and whether an office visit or whether there's a need for routine cultures in an uncomplicated UTI situation. We also basically the use of generic oral contraceptives. Ultimately, maybe a guideline where we could suggest always prescribing a generic as your first start, rather than using the samples and writing for a brand name is a good way to go. There's also some data that shows that our treatment of uncomplicated yeast infections, there's some benefit possibly to using either over-the-counter medications or and providing that maybe actually for the patient. That's a possible idea. You see a patient in your office for an uncomplicated yeast infection. Some offices are actually doing a FERN testing also, which just increases cost, rather than just doing a wet mount, a KOH, and a pH. If you look at the way that we diagnose these conditions and then how we treat it, there may be actually benefit if we can provide over-the-counter creams like Monostat 7 for our patients, rather than even generic diflucan, which is more costly. And if you do provide an over-the-counter medication, that's no provider cost at all if it's over-the-counter. So that's also a benefit to us as a group. And then for BED, routinely, it's been shown that oral metronidazole is as effective, if not more effective, than Metrogel vaginal. And the costs are significant. We're talking about a treatment course costing $1.51 for oral metronidazole versus $19.71 for Metrogel. And so, these are areas where it's fairly easy to change the way we interact with our pharmaceutical reps and how we diagnose and prescribe medications that will have a huge effect on our generic usage rate, as well as our overall total cost. Just to kind of show you some of the new medications that are becoming on generic that we use very commonly. The top 12 brand name scripts at UP attributed to ObGYN providers in 2012. Number one was Vivol Dot. Well, it's now available as a generic, and this actually accounted for about 11% of all scripts written for a branded drug. So this is an area that we could really have a big impact. The second, low-estering at 24-FE. Consider using the generic when it is available. Premarin is an expensive medication, and if we use estradiol orally, 1 or 2 milligrams instead, that would give significant cost savings. And there's a few more there: Vagifem, orthotricycline low, NuvaRing, and using Prempro, and consider the generic Activella, or the generic Fempart. Low low-estering FE. Consider whether it's just acceptable to use the generic of low-estering 120. Diaz, which is a generic for Yaz, is available. Evista is not currently available as a generic, but should be coming soon. And then there's also Estrace, generic estradiol tabs could be substituted for that. And Prometrium, which is now available as a generic also.
Mike, if you could go to the CAVE document.
So Jeff's going to go over now some CAVE data, which kind of shows the bigger picture of total cost of care, which I think is really important for you to pay attention closely to this. It's a little confusing, but becomes straightforward and is one of the top measures in the Blue Cross Blue Shield uplift.
So let me give you a brief explanation on what CAVE is. First of all, CAVE is actually the name of a company that produces a provider efficiency report. And the report essentially is based on episodes of care. An episode of care is created around a medical condition, which is based on a diagnosis, and includes all the treatment, services, visits, pharmacy associated with that medical condition. And the reporting system is really used by a number of payers. In this case, it's referring to the Blue Cross Blue Shield of Michigan data over a 2-year period through September of 2012. The methodology that CAVE uses basically compares similar episodes across a common medical condition for each specialty group, in this case ObGYNs, and it throws out all of the high severity cases, and it throws out the extreme low or high cost outliers. Essentially what it's trying to do is give everyone kind of a bread and butter market basket of medical conditions that are commonly treated by this specialty. And what they do is they make comparisons to a peer group. In this case, the peer group is all of the ObGYNs or anyone providing women's health care across the state of Michigan. This right here is an overview report of the entire United Physician population. They create an efficiency score. If you can scroll up, I don't know how much the people on the webinar can see, but at the very top right, there's an efficiency score. It says 1.03. You'll also see that in the column average cost under the title average cost per episode. There's 1.03. It's the provider group efficiency score. That represents our efficiency as a UP population compared to the rest of the state, which is the peer group. A higher score above 1 means that we're less efficient. A score below 1 means we're more efficient. So 1.03 means overall, for the entire population, we're just a little bit less efficient than the peer group average. And for purposes of the uplift, even being at the average is not necessarily good enough. They're only providing the uplift to the top third ObGYN practices. Just to give you a little perspective of what we're trying to shoot for. They break the report out into different areas based on where the care is received or who's providing the care. So you've got professional and outpatient care, you've got inpatient care. They break costs down by outpatient facility, inpatient facility, etc. You can kind of see the graph here. What I wanted to call your attention to was further in the report, Mike, if you could go to page 5, they actually break the report down into the different medical conditions and do the same thing across these different service categories. They're essentially using a standard cost. So one of the first things you may be thinking is, all right, well, I see a lot of facility stuff here. Beaumont Hospital is more expensive. Not necessarily the case here, because what they do is they take an average cost for, let's say, treating endometriosis. If you could kind of hover over that, Mike. Thanks. They essentially take an average cost of what it would take to treat endometriosis. If there's a professional visit, they standardize that cost for all ObGYN providers. This really accounts for the differences or the variability in provider contracts and regional cost differences. So I wanted to point out endometriosis because this shows, hopefully everyone can follow on the webinar, if you look at the average cost column, that's the total average cost of the PO, which is the entire population of United Physicians, compared to the peer group. So we had 93 episodes and there were 1,900 episodes across the state. We are much more efficient in treating endometriosis versus the peer group. And that's a good thing. There's a lot of really good things to take away from the CAVE data that we're seeing, that we as a UP network are more efficient in treating these different types of conditions compared to the peer group, which is the average. However, one of the significant medical conditions that contributes to our overall cost is the single newborn normal and single newborn complicated. Those are two different episodes surrounding the prenatal, birth, and postpartum care provided to the mother. This does not include any care provided to the infant because it's only looking at a population of 18 to 64. An episode of care takes into account essentially all the care that's provided over that period of time. We are, if you look at the PO score versus the peer group score for the total average cost, we're much higher. And we kind of see, as we move across the page to the right, we kind of see the different categories that seem to be driving this. I'm going to point out 3 here. One is the professional visits, the second are diagnostic tests, and the third is the pharmacy. John touched a lot about the pharmacy before. We tried to get a handle on where this essentially was, where this was coming from. If this was a utilization problem, if this was a hospital problem. The good news is that they provide us a report. They provide us a utilization report in addition to this cost report. So when we looked at the hospital piece to the right side of the page, we didn't really see that there was a main driver from the hospital that was really causing this. However, with the diagnostic testing in the outpatient center, there could be a lot of opportunity with maternal fetal medicine folks for some collaboration. But what I wanted to get to was, if we could go, Mike, to page 6. I'm sorry, page 7. Page 7 essentially is the very same report looking at the very same medical conditions, but this is a utilization report. This really just complements the cost report, and we were seeing the very same patterns. If you focus on those 2 episodes, the single newborn episodes, and you scroll across the page to the right, we saw the very same patterns in professional visits, diagnostic testing, pharmacy, and an outpatient, which led us to believe that it's really a utilization problem that we're dealing with here. Some of the things that we talked about before with pharmacy could be utilization-based. we're prescribing more brand name drugs, or we're prescribing drugs that we don't need to prescribe. With the Pap testing and ovarian cancer testing, those are diagnostic tests. Just to give an example, may not necessarily be always in the newborn care, but those are examples of areas that could be leading us towards higher utilization in some of these medical conditions. So if we could go back to the slides, Mike, on slide 19, I wanted to just offer some questions, and this can be kind of open for discussion. Are there areas that we could focus on as a group specific to the cost of care for the normal newborn or complicated newborn episode that may yield a better efficiency and will help all of us achieve the uplifts and reach our end goal of the organized system of care? So these are questions. I think we've got 10 minutes left in the presentation here. Maybe this is a good point to open it up to some general questions.
All participants are now in interactive talk mode.
So we've unmuted everyone's phone. If there are any questions, please feel free to just ask them over the phone, or you can type them into the chat box if you're on the webinar.
I just have a quick question. This is Betty Chu. Can you hear me okay?
Yes.
And what percentage of the uplift is based on the cave reporting? Is it 70% or 30%?
Great question. Let's go back, Mike, to slide 14. No?
20%.
The answer is 20%. I wanted to show the... Actually, if you can go back to slide very early. 9. I'm sorry, slide 9. So everyone can visualize it. Yep. Yep. So they actually separated into positions that are gynecology only versus the ObGYN, which is the difference here. If you look at the very top, cave is 20% if you're an ObGYN or 25% if you're a gynecologist. The important thing to know is the first two measures, so cave and the women's cost of care, those essentially are cost measures. They're total cost. To simplify things, they account for of what goes to the output. So at the end of the day, if you have anything to take away from this, it's cost.
You know, can I just say something? We had some data that we were shown in our steering committee about the cost per member per month averages between the UP doctors, Beaumont physicians in general, and then the other physician groups in Michigan. And when you look at the per member per month cost of care for women's care, we are significantly higher than the Blue Cross average and higher than the others in our immediate market area. And we're only ahead by about $10 a month. I mean, it's $10 a month, it's $120 a year just to get to the average. So that's one prescription drug that you prescribe that's a brand name instead of a generic. You'll save way more than $120 a year. If you switch someone from low estrin 24 brand to a low estrin 120 generic, you'll save way more than $10 a month, and you'll put your back to average, so or below. So that's just
hi.
easy point.
Hi, this is Joe Beal.
Hi,
Can I
Joe.
ask two quick questions? Hi, Kathy. Yeah, we've gotten lazy. We do vaginal cultures on all our patients instead of doing wet mounds. I mean, that could be a substantial savings right there, can't it?
Absolutely.
Yes, that's true.
Absolutely.
Because how much do those cultures does Beaumont charge? They probably charge $75.
You know, I don't know that answer, but I'm sure it's more than a wet mount.
Right, but even, Joe, if you get reimbursed, let's say, $70 for the visit to treat the vaginitis, even if your test is only $7, you increase that cost 10%. So if the test is 70, you doubled your cost that is compared to our peers that were just. I think that's a very good, simple observation. I changed some practices just working here about how I treat uncomplicated UTIs. I was sending out probably way more doctors than I did after the primary care doctors and how they were treating them. But I think that's a great example. You said you had a second question?
The second point is, sometimes I'll tell my patients to get their free medication at Meyer. I mean, does anyone else do that?
Oh, yeah.
That's exactly what we did with our patients in our employed side. We would just send them to Meyer. We definitely give them a generic prenatal vitamin, and it was provided for them either free or for $4. And we're talking about 90 days worth. So it's a huge cost savings. And there's really, from our standpoint, there's no difference in whether it's a branded prenatal vitamin or generic. We've been shown that time and time again.
One of the things I want to point out again, I'm kind of waiting for someone to say, well, it doesn't matter my generic dispensing rate. Yeah, it could. However, where the market's going right now is the total pharmacy cost and away from generic use rate. I think that Blue Cross is looking at moving that way because there's a saturation that's been reached with generic use, and it's more important to focus on the total pharmacy cost versus, well, I just want to throw my generic use rate through the roof because I'm ordering all these generics when they could get something free at Meyer, or you could do the Monostat 7 and over the counter. So I just wanted to point that out in case.
Yeah, I think as far as the generic prenatal vitamins go, if you think about it, and if I think about it, if I didn't have brand name samples in my cabinet in the office, I would never write for a brand name prenatal vitamin. And how can I change my behavior? I can stop having samples in my cupboard. We don't need them. They're free. So.
Another question?
And patients can be educated about why we don't have samples anymore. I've done it for the past 5 years, and it's been ultimately they see the light. They really do know that we have their best interest at heart.
Any other questions on the line?
Got one more slide about
yeah. So we have one more slide at follow-up, but just a few things. Those of you who are assigned as organized system of care, this does count as one of your required meetings, and we've kind of taken attendance of the people that have been on, because you are required to participate in 2 meetings a year to remain an organized system of care physician. So this does count as one. 2, we're going to go through some next steps, which I'm going to let them do. And 3rd, I think you should be alerting your office managers to the importance of this that you participated in, so they are receptive to the forum that's going to be taking place very shortly following this webinar.
Okay, so as far as next steps from our ObGYN colleagues, we are looking for volunteers. You can email me. I'm at cstark@beaumont.edu, or you can email Mike Genord. He can get it to me too. He's at United Physicians. But we need to start working on more specific clinical guidelines, and we really have a goal, a long-term goal in mind to work with the hospital, both the MFM departments, to kind of standardize our antenatal testing and our ultrasounds to try and shore that up and make sure we're not doing unnecessary testing, but doing it according to evidence-based guidelines. So that's a big group. We need to work with the hospital about induction rates. We have problems with our cesarean rate, but this is a really complex problem. We really stand out when we compare Beaumont physicians to the state of Michigan in our overall cesarean rate, in our induction of labor rate. We're pretty good at deliveries before 39 weeks, so I don't think we can go too much farther there, but still it's something to keep in mind. I think, as we...
Can I touch on the induction of care? just to be clear on that, the difference in total cost if someone comes in active labor to a patient you induce even with a favorable cervix is significant. There's significant more hospital time, there's significant more drug, there's significant more cost delivering that care. So when we're talking about total cost of care, even inducing at 40 weeks, though it's not before the 39 weeks, you are increasing the cost of care by managing that patient that way as opposed to waiting till later and having them spontaneous go into labor without a complication. Obviously, there's reasons to induce, and we're not talking about that, but...
Right. So that's where we're looking long term. As for now, what can we do for low-hanging fruit? Consider adopting an office policy for your mid-level providers that they cannot write brand name scripts. DAWs have to be signed by a physician only. You can have an office formulary for increasing generic drugs. And what we're thinking of is an office policy that all new start OCPs start on a generic. Consider getting rid of samples in your sample cupboard, limiting access to the drug reps, and really think about it when you write a brand name drug, could you use a generic? Just be aware that $10 a month is not a big way to move the needle, and it'll put us from being the most expensive to one of the better performers. So that will make a difference. And then consider working more with our United Physicians staff and members of the steering committee. We expect to have a couple more meetings in 2013. We welcome some additional members to our group. And we hope to get back to you in a follow-up webinar in September or October with some further evidence-based clinical guidelines. Thank you.
Any other questions?
No,
Well,
yes, Mike, thank you. Thank you for your volunteer efforts and hard work.
Yeah, well, I really want all of you to walk away and share with our colleagues that you participated. We tried the webinar to be less disruptive to our schedules, not evening meetings, morning meetings, things that you could do in your own office at lunch. But I think it's really important to share among them what's going on, that UP is really working hard. And secondly, to encourage them to participate in future webinars. We had a fairly good showing here of participants, but we can do a lot better as a department of getting people to sign on. But I want to thank all of you for the time, and please reach out because we need more volunteers, and we want to certainly get buy-in from all of our colleagues. So the more voices we have to the table, the better we're going to be at getting buy-in. So have a nice afternoon, and thank you.